Hello everyone, welcome to AACCM learning channel. I'm Dr. Ankit and today we'll be discussing something about hypernatremia as we've left in the previous video, right? What is hypernatremia? It means serum sodium more than 145 milliequivalent per liter, normal values being 135 to 145. Anything which is beyond 145 it is hypernatremia, right? And the important which we have to know is it is a less frequent disorder. Doesn't happen that well, doesn't happen that frequently in the patients, right? And how it happens, we all know there is a combination term, sodium and water retention, right? If there is loss of free water, we call it loss of free water, right? This causes hypernatremia, or if there is a gain of sodium in excess of water. Okay? Okay. Right. So you should know that hypernatremia is usually due to water deficit and not sodium overload, right? You should know this, an important thing. And what are the risk factors? What are the risky scenarios in which we can find this composition, this hypernatremia? Extremes of age, debilitated to sick patients who are having comatose, or if somebody is having severe vomiting, right? These are the scenarios in which we will find hypernatremia, right? Now let's see what is the classification of hypernatremia. Classification of hypernatremia is again divided into three types. Hypernatremia with hypovolemia, hypernatremia with hypervolemia, right? There is a rare scenario whereby all the three conditions can exist. And hypernatremia with euvolemia. All three conditions can show this particular scenario. If somebody is having hypernatremia with hypovolemia, what will be the cause? Simple thing. There is less volume of water and there's still high sodium. This can be either in renal water losses, like somebody is having use of osmotic diuretics, right? Renal tubular disease, or somebody is having adrenal failure. In these scenarios, there will be renal water losses and there will be hypernatremia per se in rare scenarios. And in this case of adrenal failure, there will be, impaired response to ADH, antidiuretic hormone, and diabetes insipidus. That will lead to increase in urinary sodium more than 20 and urinary osmolality less than 300. Right? This is about the renal water losses causing hypernatremia with hypovolemia. Now let's talk about the extrarenal losses having the same scenario, right? Extrarenal losses or non-renal water loss causing hypernatremia with hypovolemia. Right? This will be when will the water level of the body goes down in case of GI losses, right? Like in diarrhea, isn't it? Severe vomiting, severe sweating, burns, exercise, right? Heat exposure. All these scenarios can lead to non-renal water losses causing hypernatremia with hypovolemia. Right? Let's talk about hypernatremia with hypervolemia, the second cause. It will be either iatrogenic, cause is unknown, with sodium containing compounds. Very important thing to know here, there will be mineralocorticoid excess. Right? This will also lead to the same. Examples being aldosteronism, Cushing's disease. Right? In these scenarios, there will be mineralocorticoid excess and it will cause hypernatremia with hypervolemia. With euvolemia, important thing to know, again the same causes will continue. Either the extrarenal or renal water losses. Extrarenal water loss being diarrhea, fever, somebody is having fever, diarrhea. This will be extrarenal water loss. When somebody is having diabetes insipidus, renal disease, right? And somebody is being diabetic, which will cause the renal water loss, right? These are the reasons for hypernatremia with euvolemia. Okay. Now let's talk about what are the clinical features of the same. We have talked about this particular thing in a previous video, that if somebody is having hypovolemia and somebody is having hyponatremia, what will happen because of that? The body will try to retain water, right? The cell will get swelled because of water and there will be cerebral edema in that particular case, right? Or cell swelling. But in case of hypernatremia, what happens? The cell loses water. Because of that, what will happen? The cell will tear it out itself from the basement membrane. It will cause tearing, will cause hemorrhage in the cell basement membrane and the junction between the cell and the basement membrane, right? So in this particular scenario in hypernatremia, what happens? There is water loss. So there will be, in case of neurological features, there will be, what will happen? There will be dehydration of CNS. This will cause cell tearing and that will cause hemorrhage in the brain and spinal cord, you can say. Right? Serious features, there will be volume depletion we are seeing here in hypernatremia, right? So body will go in shock, right? Because of that, the renal features will occur. That will cause, initially there will be compensatory response causing polyuria. Later, that will cause to oliguria and ultimately causing ARF. Right? This is about the clinical features of hypernatremia. Now let's talk about the management of the same. Anything which has management will have two scenarios. Either it will be acute or it will be chronic, right? And if it is acute hypernatremia, it has to be treated rapid. If chronic, you have to treat slow, right? Because of this, what particular scenario happens is the chronic hypernatremia getting treated fast, there will be neurological insults in the body, right? The water will enter so fast in the cell, it will cause cerebral edema. You're already dealing with hemorrhage, you don't want cerebral edema to happen in the patient, right? So we have to treat slowly in case of chronic hypernatremia, but in case of acute, you have to treat it rapidly. What is the correction rate? It should not exceed 2 millimole per liter per hour. This is the maximum correction rate of hypernatremia, right? I'll also treat the underlying cause. Right? You have to deplete the volume with isotonic saline, right? Use hypotonic fluid after volume depletion. You have to replace the water deficit within 24 to 48 hours. And if there is sometimes sodium overload in the body, you use the diuretics, preferably loop ones, right? And if that doesn't count, that doesn't help, you have to go for renal dialysis if somebody is having severe scenarios on this particular thing. Thank you so much for today's video. We'll be discussing hypercalcemia in the upcoming video. Till then, keep subscribing, keep learning. Goodbye.